Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. In today's episode, we discuss how specialist pharmacists can help overcome barriers to HIV PrEP, especially among key populations. I'm delighted to be joined by two pharmacists, Dr. Tessa Rife-Pennington at the UCSF School of Pharmacy and Dr. Frank North at Texas A&M. To follow along with the slides, visit the show notes for this episode. Now let's get started with Dr. North.
I think it's important for us to really be able to start and to give an overview of PrEP and its users and opportunities for pharmacists in this space. So we want to look at what is a PrEP, and many people that may work in this space may be familiar that PrEP is pre-exposure prophylaxis, and it's a medication or medication regimen that's used by individuals who are not currently living with HIV in an effort to prevent acquisition of HIV from sex or from injectable drug use. If PrEP is taken consistently, and we'll learn about the various ways that it could be taken, but if it's taken consistently, it reduces the likelihood of acquiring HIV from sex by up to 99%, and from injection drug use by about 74%. When we look at the U.S. trends of people who could benefit from using PrEP, even though there is an increase over time of acceptance and use of PrEP, that there's still some disparities amongst racial groups in the use and uptick of PrEP. And so we're going to dive more into why this could be in this particular presentation. So we see that white individuals have about 94% uptick compared to Latin and Black counterparts at 24 and 13%. CDC recommends guidance on PrEP candidacy. So this is a method and an opportunity to drive conversations about PrEP. All pathways lead to either prescribing PrEP or having a discussion about PrEP, which is seemingly not always happening in certain care practices. So if a person is engaging in anal or vaginal sex in the past 6 months, there's a pathway to have a conversation whether or not their partners may or may not be living with HIV, and if their status is unknown or known, then there's an opportunity to prescribe a PrEP for the individual if the individual is not living with HIV at the time. If the person may not be ready or may not know, there's an opportunity to still have a discussion about PrEP at each visit. And again, you see this at every encounter, whether or not the person has more than one partner, whether they know the status or not, or whether the person has an STI or STD. There's always an opportunity to provide conversation about PrEP or to initiate PrEP in that particular patient. So when we think about individuals taking PrEP, usually they're individuals that are seemingly missing from the conversation. So I was at an event and I was having a conversation with someone, and a random person started having a conversation about the commercials or the media, the marketing that you see for PrEP, and it's usually Black males. But we also want to talk about who have sex with males. But we also want to talk about individuals who may be missing from this conversation. And so when you think about individuals who have sex and could benefit from using PrEP, oftentimes cisgender women are left out of the conversation. And there's this myth that they have a low likelihood for acquiring HIV, and especially if they are married. Heterosexual men, the myth is that they have a low risk of HIV acquisition, especially if they're married, because they are not having sex with men. And then people who inject drugs, often individuals who are left out of this conversation, because we often associate HIV and PrEP use with individuals who may be sexually active. However, there's opportunity for us to really include these individuals who may be injecting recreational drug use. And transgender women, and unlike we see with cisgender women and heterosexual males, we see this stigma and this fear, and with the medical systems that don't often allow for appropriate and safe uptake of these individuals for appropriate care. So next, I want to highlight the prevalence of HIV and PrEP use in transgender women. That was a missing population, and one that is really, tormented with fear and stigma and all of the things that may affect individuals in general with uptake of PrEP, but at an enormous and a heightened rate. So transgender women are 34 times more likely to be living with HIV than the general population. However, their prevalence estimated is about 14%, which is likely underestimated because they may not be seeking care or are able to have psychological safety in order to be tested appropriately. In 2019 to 2020, the National HIV Behavioral Surveillance of 7 cities, Atlanta, Los Angeles, New Orleans, New York, Philadelphia, San Francisco, and Seattle, found that there was a high PrEP awareness, but a low utilization. So HIV negative transgender women were about 902, and about 91.8% of those individuals heard about PrEP, but only 32% were using PrEP. So large opportunity for us to continue to have those discussions with individuals who may have heard about it, and give them opportunities for a safe uptake to use it. So I want to talk about PrEP uptake recommendations in individuals who inject drugs, and I want to highlight that a cornerstone of all conversation, of all uptake of PrEP, is really having the conversation, and having the conversation in a respectful way that doesn't always position the risk that the individuals may have rather than the reasons why they should be protected. So 1 in 10 HIV diagnoses are in people who inject drugs. Among those individuals who inject drugs, PrEP awareness has increased from about 26% in 2018 to 35%, but the PrEP use remained low at a stable 1.2%. So again, having the opportunity to continue to spread awareness, but maybe leveraging some of our motivational interviewing to move the individual from just not being aware of it to actually utilizing PrEP to prevent them from HIV. CDC guidelines recommends PrEP for people who inject drugs in combination with other substance use disorder treatments, having more conversations about PrEP that can hopefully lead to them being prescribed PrEP. So we're talking about PrEP and what the discussions are. Here are some of the current PrEP options that are there. So I want to draw your attention to 2 different options. One is a once daily tablet or oral tablet, and the other long-acting injectables. So we'll look at the once daily oral tablets, emcitabine and tenofovir dispropyl fumarate, or TDF FTC. This is a one-time daily tablet, and then there's a new formulation that has a different formulation of tenofovir alafenamide with emcitabine, or the FTZ. And this is this is FTC TAF. More recently, we've had the availability and the FDA acceptance of long-acting injectables, cabotegravir. Cabotegravir is a 600 milligram IM once a month, every 2 months, and then 600 milligrams every 2 months within a particular window. So an individual will come in and they will get a dose of the long-acting injectable, and then they'll return the next month and receive it, and then from that particular month, from that particular dose on, it's every 2 months. And even more recently, we have the FDA approval of lenacapavir, which is kind of under this umbrella of 2 to go, where you can have just 2 injections per year and have prophylaxis or protection from HIV pre-exposure. We'll dive more into these PrEP options. So the person is engaging in insertive anal or vaginal sex, and we use the term insertive anal sex as bottoming. For males who have sex with males, they have an opportunity to really engage in any of the PrEP options that's available. One of the options was the on-demand 211 FTC option. For individuals engaging in vaginal or neovaginal sex, there's a reduction in the opportunities for individuals. So the daily TDF, TDF, FCC is available for these individuals. However, these individuals who are cisgender women are not candidates for the on-demand method or the TAF tenofovir pathway. We do see some benefit of our long-acting injectables when we talk about our creatinine function and our kidney function, as well as opportunities when we have women or individuals who have osteopenia or osteoporosis. We talked about on-demand, and so here's what on-demand 2-1-1 PrEP regimen look like. And so this is based off the timing of someone who has sex. So this is someone who may want to plan their activity. So when we talk about having sex, we want it to be pleasurable. We want the individual to have time and get the desires that they want and not be judged. And so this on-demand gives the individual a male who has sex with a man to really kind of plan their excursion. So they can take 2 tablets 2 to 24 hours before the sexual encounter, and then they can take 1 tablet 24 hours after the first 2 pills or first 2 tablets, and then 24 hours after that. So 48 hours after the first 2 tablets, they take another tablet, and this usually prevents them from acquiring HIV. So it's important to note that this is not FDA approved, but it is recommended by the ISA USA guidelines, and it is not recommended for HPV co-infections and different things of that nature. So we talked about these different types of HIV PrEP modalities, the 1-a-day tablet, the long-acting injectables. But what happens when your patient wants to know how these particular medications will work and when they will work based off of when they would take? So here's some counseling pearls for you. So after the individual starts taking PrEP oral tablets, they have 7 days for protection if they are receptive anal or bottomy in their experience. For receptive vaginal sex or drug use patients, we usually see continuous daily use of about 21 days for protection in these individuals. And even though we do have the options of our long-acting injectables, and the data is still out on how long they work. But guidelines do recommend if starting long-acting injectable like Cabenuva, that individual first starts with a daily tablet and then overlaps, and so then they will have that protection of the oral tablet as they move into the long-acting injectable. And the same with the lenacapavir. There is a 2 tablet plus 2 injection on day 1, and then 2 tablets on day 2. If the individual is suspected to have had an encounter with someone who they either don't know the HIV status of, or someone who they do know the HIV status of is positive, there is an opportunity to start PEP, which can be started within 72 hours of the activity, and it's taken for 28 days. And then after that, PrEP can then be initiated if the individual is negative. So when we talk about long-acting injectables or injections, there's always a risk for injection site pain or post-injection. So here are some post-injection recommendations for you if you are giving your patients these long-acting injectables that usually go into the gluteal muscle or the side of the hip. You can apply ice before and after the injection to aid with soreness, apply topical analgesics or oral analgesics. It's important that when you remove the needle that you prevent any leakage of the medication from coming out of the injection site, and then applying a bandage. I'm new to this space, and when I did my observation, one of the things that was common for patients is that they talked about that the injection site pain usually went away if they did some type of physical activity during that particular day that they got the injection. So just some additional counseling pearls. So we want to talk about overcoming barriers to PrEP access and its use. So some key barriers by principal populations, adolescents, racial or ethnic minority groups, cisgender women, transgender individuals, and those who inject medications. So adolescents usually have a dissatisfaction with the medical care team, and they may feel like they have a lack of support from either their parents or adults around them when they may be trying to protect themselves from the pleasures that they may be experiencing sexually. With racial and ethnic minority groups, there's a history of medical mistrust and stigma and PrEP misconceptions. So some individuals feel like the taking of the PrEP medication is in some way may be introducing the virus or HIV to them. So really having these conversations and demystifying the misconceptions that individuals have centered around PrEP is important to make sure we're maintaining the trust in the individuals from a medical perspective. So sometimes some concordance in the provider may be helpful in having those particular conversations. Cisgender women's barriers include competing priorities like poor PrEP awareness. Individuals have reported that sometimes they don't even have the conversations with their provider, and oftentimes if they bring it up, their provider is telling them that they're in a monogamous relationship, and so their activity or their risk don't warrant them the precaution of PrEP. However, we know that the indication for PrEP use is anyone that's having sex. And so if you're having sex, then you are a candidate for at least the discussion and the start of PrEP in your patient. And I know we can sense in today's climate, there is a polarization when it comes to transgender individuals or individuals who present differently. And so this is exactly the barriers that are seen in terms of medical mistrust, the stigma, and the transphobia that is encountered by these individuals. And then if they are engaging in PrEP or want to engage in PrEP, we have to take into consideration drug interactions with their gender-affirming hormone therapy that they may be taking. And then individuals who inject drugs, some key barriers are cost, ability to remember to take PrEP daily, social barrier, because usually these individuals may be unhoused or face other stigmas that are associated with their recreational use of drugs. And then we have structural barriers to PrEP with regards to insurance coverage. So again, in our current climate, we see a lot of reduction in support services for individuals who may be uninsured patients with access to PrEP. We see a 4 times more likely chance of PrEP use in individuals who are insured and have the opportunity to acquire PrEP. Continued structural barriers to PrEP with informed consent for minors. Consent laws vary across states, so it's important for you to know your state laws that's specific to your state. In some states, minors are allowed to give informed consent and receive specific STI or HIV services, including PrEP. However, some states have to engage in these particular services with their parent or guardian. Parental insurance coverage may not guarantee confidentiality for minors. States allowing minors to autonomously give informed consent to receive PrEP does not guarantee their confidentiality with their parents. We have our social determinants of health. Again, the education and the conversation and discussion centered around PrEP is a great way to increase our knowledge and our awareness, and hopefully our uptake of PrEP use amongst individuals who are having sex with other individuals, whether they know their status or think they know their status. Social determinants of health are non-medical factors that affect a wide range of health risks and outcomes. They include where people, work, play, and go to school. So it's important to make sure that there are these conversations happening in various communities and at various levels of where we engage in our life. The overcoming barriers to PrEP access and use, the role of the pharmacist. So CDC reports that PrEP prescribers in the United States from 2014 to 2019 has increased from 9,621 to 65,822 in 2019. So we do see an increase in prescribers having and engaging in these conversations, but we still see the disparities that were presented earlier in this presentation. So the increases in those who prescribe PrEP from 2019 were all U.S. providers from 0.7% to 4.3%, primary care physicians 1.8 to 13.6, and then ID physicians 14.2 to 32%. So pharmacists have an expanded authority to dispense PrEP or PEP in 17 states and independently prescribe PrEP or PEP in 12 states. Some of these states are still in the implementation phase of what this looks like in order that gives pharmacists the authority to dispense and independently prescribe PrEP. So it's a great opportunity for you to look at what your state is doing and seeing what phase it's in, so you can be a part of the conversation about increasing the opportunity for individuals to have access to PrEP. The landscape is evolving with state-based legislation regarding PrEP barriers, and instead, the notes that pharmacists are accessible healthcare providers and they are uniquely positioned to address these barriers. So individuals may engage with their pharmacist once a month. So there's always an opportunity to have these comfortable conversations about how they are experiencing sex in their lives, and then the opportunity to increase their opportunity for PrEP. States are increasingly passing laws that permit pharmacists to initiate or administer PrEP without requirement of a prescription. So it's a good opportunity for us to be involved in our state associations and other legislative affairs, so we can increase the opportunity for pharmacists to provide these services.
Thank you, Dr. North. So now we're going to talk more about pharmacy-based PrEP. This recent publication highlighted a time series cross-sectional regression analysis examining how pharmacy policies shape PrEP uptake, and that one type of policy in the US are stopgap type policies where pharmacists can initiate PrEP and prescribe for a short time limited window, as compared to policies that allow pharmacists full prescribing authority. And they found a clear difference between the two, where the stopgap authority showed no measurable increase in PrEP uptake compared to full prescribing authority, which showed an increase in 25 PrEP users per 100,000 people. And that was about a 14% increase relative to the mean in 2023. So in other words, when pharmacists are empowered as ongoing PrEP prescribers, not just a bridge to treatment, the population level uptake improves. Okay. Community pharmacies are a really excellent setting to start offering PrEP services, and this fits right in with other types of medication therapy management services that we offer. It might seem daunting at first. So what does it take to get started offering PrEP from a pharmacy? And this paper lays out a really doable checklist for one-stop shop PrEP services. It covers how to perform initial consultation, prescribing PrEP, navigating insurance and billing, monitoring labs and follow-up, and really providing staff education. This model was implemented in San Francisco, and in just about 1 year, they found 53 patients completed an initial PrEP visit, and 96% filled the initial prescription. A similar study was evaluated for a pharmacy program based in Seattle, and they looked at longer-term 3-year outcomes. During that time, 714 patients were evaluated for PrEP, and over 97% initiated PrEP. Importantly, 98%, most of the patients had no cost for their PrEP services. And there were about 19% lost to follow-up and 25% dropout. But what they clinically important that they found was that there were no HIV seroconversions in the group. So bottom line for your pharmacy teams is that if you are able to co-locate the full spectrum of PrEP services, so the evaluation, labs, prescribing, dispensing the medications, and helping patients navigate cost coverage, all co-located within a community pharmacy setting, you can achieve fast PrEP starts, high adherence, minimize cost for patients, and keep strong retention and care. And this study by Krosapor and colleagues evaluated a pharmacist-led same-day PrEP in Mississippi. This was a non-clinical HIV and STI walk-in clinic or walk-in center, and patients would undergo rapid HIV testing, and HIV negative patients would meet with the pharmacist who was working under a collaborative practice agreement. They would assess contraindications, provide counseling, and issue a 60-day PrEP prescription with the plan that the patient would have the full baseline lab workup within the next 6 weeks in a clinic setting. In just 7 months, 69 patients were evaluated. Notably, there were 77% Black individuals and 65% were uninsured. All of them received a PrEP prescription, and 77% filled the prescription. However, they had a larger loss to follow-up. So only 43% who filled their prescription came back within the next 6 weeks for their follow-up labs. And so what this really highlights is the importance of co-locating the full spectrum of PrEP services all in one place. The labs are important to co-locate with the PrEP services. Some practical steps for launching or strengthening PrEP in your community pharmacies. We want to put together our collaborative practice agreements, get our state protocols, policies in place so that pharmacists can initiate and continue PrEP and order labs. We want to work out our lab testing logistics. So we're going to do on-site labs in our pharmacy or send out labs. We want to have quick intake questionnaires so we could do brief medical and sexual health history. We want to identify and work through our pharmacy space so that we have a confidential space for having sensitive conversations, for collecting labs, as well as if we're going to administer long-acting injectable PrEP in the pharmacy, we need a private space to do that. We also want to set realistic goals for how much time a PrEP visit will take, how much time we need for documentation, and work that into our standard pharmacy workflows. We want to utilize our communication tools, text messaging, electronic health record alerts, train our staff on how to have conversations about PrEP. And then reimbursement is really important. So you can work on short-term grant funding, obtaining 340B contracts, negotiating directly with insurance companies, and finally, advocacy for our profession will always be important. We want to advocate for pharmacists as not just PrEP providers for initiation, but also being able to continue maintenance therapy. So here's some practical strategies, things every pharmacy team can do, even if we can't prescribe PrEP or if you don't have full prescribing authority. So we could use routine touch points with patients as teachable moments. For example, if a patient's coming in for emergency contraception or treatment for an STI, we could start with this simple one-liner. While we're here today, would you like to hear about how PrEP prevents HIV? Or have you heard about PrEP? Would you like to talk about it? It just really opens the door for a conversation. We can be PrEP champions in our workplace. We can normalize the conversation around PrEP, provide training to our technicians, our interns, our staff. And I always love to have a good news story or a success story. It really helps with buy-in and generating interest and keeping people engaged, whether it's staff training, training learners, or even sharing stories with our patients about PrEP success. You can be a PrEP champion in your workplace, making PrEP information more visible, like posting signage, QR codes to local PrEP telehealth programs. You could have electronic messages on TV screens about PrEP, or even launching a PrEP academic detailing campaign, especially if you work in an integrated healthcare system. I really love tabling events. There's many HIV, STI, and substance use awareness days throughout the year. So you could host a tabling event, and even co-locating STI and HIV testing at the event would be an amazing way to increase awareness. And finally, data tools are your friend. Many health systems have clinical dashboard tools or electronic health record reports where you could identify patients that might benefit from PrEP. For example, patients who had a recent bacterial STI And you could call them over the phone, send them a letter or a text message with just some brief information about PrEP. Key strategies we want to incorporate to reduce PrEP inequities. We want to normalize the conversation, offer PrEP to all patients, and not make assumptions about who we should selectively offer PrEP to or PrEP information to. We want to integrate PrEP into our electronic health system tools. We can use our telehealth visits, video visits. I mentioned text messaging, mobile apps. I really like it when healthcare systems have like messaging tools so that I can do things online rather than having to make a phone call. Long-acting options are, as Frank mentioned, much more convenient, especially with the twice-a-year option. So people are not having to think about PrEP every day or plan around the time of sex. And also put in a plug for Together Take Me Home. It's a great free resource where people can go online and get a free HIV self-test mailed to them every 3 months. And depending on what region you're in, you can sometimes also get other free STI testing. So using patient self-testing as a tool is a great way to address barriers like cost, transportation, limited operating hours, and stigma of having to come in for testing. Cost for medications is definitely one of those barriers we want to try to address for patients. And so 3 strategies to remember: patient assistance programs. They offer no cost or low cost medications to people with no insurance. Or whose insurance plan doesn't cover PrEP. And there is an income cutoff for these programs. The second is copay assistance programs. And these are to support people who have insurance, and this helps cover their deductibles, copays, or coinsurance costs. The third option are state-based programs, which you can access through the NASDAD link. And many of these will support covering labs, costs for visits, insurance costs. And just thinking broadly, for people who do not have legal status in the US, or minors who are worried about EOBs going to their parents, or anyone with privacy concerns, you can really lean more on your patient assistance programs and your state-based programs. And to make this actionable, like in a pharmacy workflow, you could train your technicians and staff with a simple one-liner to ask patients, hey, we have programs that can make PrEP free. Can I help check your eligibility? Or have a quick one-pager checklist of available assistance programs. Have the fillable forms ready, fax numbers, anything you need, like an income checklist, cheat sheet, quick things, tools to help with the workflow of getting patients' medication covered. We wanted to mention that many of our work settings may be facing evolving changes at this federal and state levels. For example, terms being restricted tied to DEI, gender pronouns. And when that happens, one strategy that we as healthcare providers can use is to change our language to more neutral descriptive terms that doesn't erase the person. For example, we can reframe and change saying things like gender affirming care to saying medical treatments that support a person's health goals. Or instead of transgender woman, describe a person who is living as a woman. In addition, we can focus more on the care being provided than the labels, and focus on the specific treatments, the specific medications, specific labs, specific outcomes, rather than packaging it all under a label like gender affirming care. And this way, when our language is constrained, the care we provide is not. We can keep our PrEP services patient-centered. We wanted to emphasize the importance of really showing up well for trans, non-binary, and gender diverse folks, especially in today's political climate. Patients may come in and they feel safe talking to us. They may have very valid concerns, worrying about being able to continue their medical treatment, their child safety at work. And so just some key strategies to signal that this is a safe environment are focus on the basics. So making eye contact, using reflective listening, positive affirmations, avoid minimizing the very real concerns that they have. And during acute times of stress, sometimes it can be helpful to give people permission to set boundaries. And so, for example, when when coming home from work, setting a limit on how much time you spend checking the news. That way you can stay up to date, but also not completely spend time doom scrolling about things that are happening that can be very distressing. And there's a wide range of coping tools we can link our patients to, like mindfulness apps, psychotherapy referrals, linking them to social support networks can be helpful. I also want to mention that the words we use have a big impact. They can either invite people in or push them away. And using person centered language that avoids stigmatized words and phrases is something we should all strive to do in practice. I like to think back in pharmacy school, I learned not to say someone is a diabetic and instead to say a person with diabetes, which brings the humanity back into the conversation. So you can do similar things instead of saying an HIV patient, a person living with HIV. We can use more neutral clinical verbs, like instead of saying to catch HIV or pass on HIV, which implies blame, we could say to diagnose or acquire HIV. And avoid morality, judgment, blame with our language. So, especially like when discussing sex practices or substance use, instead of saying a person is having unprotected sex or that they're promiscuous, you could say sex without condoms or sex with multiple partners. And this really helps reduce shame, blame, improves disclosure, and keeps people engaged. And along these lines, we can transition from using a risk-based framework or risk-based language where we say a person's behaviors are super risky. Instead, we could say what their reasons are for PrEP. So one example is instead of saying to a patient, having multiple sex partners increases your risk for HIV. You could say, I hear you, you have multiple partners, and you want to stay in control of your health. PrEP can do that for you. Let's talk about how to get started. We've talked about a lot of these strategies for normalizing PrEP. Just to highlight a few, visual signs of acceptance are amazing, like a small pride pin. I really like this one that I have. It has the rainbow and says, "You are safe with me." Having just a small tool, a small message that you don't even have to say out loud, but the person you're working with can see, really means a lot. And a lot of veterans or patients that I've worked with notice things like that and will comment on it. And I think it helps create a safe space. Using pronouns on badges, having staff who reflect your community and your patients, including Black, Latine, and transgender team members, is also important. This focuses on, just to highlight, a few comprehensive HIV prevention services that we really want to offer in our pharmacy settings, adding HIV PEP or post-exposure prophylaxis, doxy-PEP, doxycycline post-exposure prophylaxis, other sexual health services like vaccines, linkage to contraception, as well as applying a harm reduction framework, which I'll mention briefly in just a moment. Quick tips on taking a sexual health history. This may not be something you learned in school. I know for me, this was new. I grew up in West Virginia in the Bible Belt, and talking about sex is really taboo. And so it's really helpful to reflect on the fact that most people have sex in their lifetime. We shouldn't make assumptions about who people have sex with or what types of sex they have, and ask all of our patients about sex. Who are their partners? What types of sex do they have? And what body parts do they use during sex? So we can tailor things like ordering rectal swab or throat swab for chlamydia, gonorrhea for people who have anal or oral sex. This is a helpful framework that you can use when asking your patients about sex and just kind of normalizing it, saying, I ask all my patients about sex, emphasize that it's confidential, use open-ended questions, and avoid assuming that older adults are not having sex. And we can use the 6Ps as a great framework for taking a sexual health history. So asking about partners, sex practices, history of STIs, what people are doing to prevent STIs, their pregnancy plan, and then pleasure, problems with sex, and pride. And I mentioned a harm reduction framework. I'm really passionate about harm reduction, and I highly encourage us all to think about offering harm reduction resources to all patients in a way that's like a checklist where you could offer all of the tools to everyone and avoid assuming that I should offer condoms and lube to this person and syringes to this person, but picking and choosing. When we do that, we miss an opportunity where patients may not be telling us about their substance use or about what kinds of sex they're having. And it just really normalizes it and opens up the opportunity for patients to talk to us about what they're doing in their lives and how we can keep them safe and prevent infections like HIV.
Found the United Nations Universal Declaration of Human Rights, which is about a 30-article declaration about just innately human rights. So when we talk about harm reduction and interacting with our patients and providing a safe space, I felt that this was appropriate to add and to include in how pharmacists are engaging with patients and respecting their rights as a human. I'd like to answer some questions that I see here. So one, are injectable forms of PrEP specialty medications, or are they administered by a healthcare provider or self-administered? They are administered by a healthcare provider, and increasingly pharmacists are providing these medications. So a part of the fellowship, I was able to shadow at Legacy Community Health, a dynamic group of pharmacists that are injecting cabotegravir to patients as a form of PrEP. This is lenacapavir being approved. How does the efficacy of 2-1-1 regimen compare to the daily continuous therapy? And according to the literature that I've been able to find, they have been accepted and effective. In that, there was a study in the UK, the PROUD study, that showed that there were largely no differences in uptake or prevention risk associated with individuals that's doing the 2-1-1. There are some articles and some literatures in the early 2020s that just kind of talk about how complicated that particular regimen is that remembering to take 2 tablets, at this time, and then when you take the next one could be problematic. But again, when we think about and when I think about individuals with adherence, if a person is not going to take their tablets every day, but then they would choose to, have the same amount of effectiveness of PrEP by utilizing and incorporating the 2-1-1, looks like that the literature supports that that's an effective method. I'll pause and see if there are questions, Tessa, if you want to take any.
Yes, there is a question from, do you know, is there an association with people getting a nodule reaction when they have lower body fat percentage? Yes, that people with a lower body fat percentage are more prone to getting nodules after LEN injections. But these nodules are a common side effect for all people using the medication. So regardless of body fat, it's not a sign necessarily that the drug's not working. So key things to do, monitor for unusual symptoms associated with the nodule, like pain, pus, fever, swelling, like unusual swelling that be signs of infection. And Carla Leiden, what's the biggest issue you encounter with regard to HIV testing in the pharmacy for PrEP staff? I personally don't practice inside a pharmacy. I'm in an integrated healthcare system. So within my system, all HIV testing, patients have to go to the lab. So that requires ordering the lab test, and then the patient goes and waits at lab, and then we get the results. One of the biggest barriers for me was getting my scope of practice approved. It took over a year just for me to be able to order an HIV test, which finally just happened last month. So I'm so excited. But just even when there are policies that allow pharmacists to do PrEP prescribing and monitoring, it can still take a long time to for us to be able to do it in practice. I think ideally we would have self-testing available. That's another thing that I would love for us to have, like even mailing patients a self-test. Like we mail fecal occult blood, like stool cards to patients to do at home and then send back. If we could do like at-home patient testing, that would be great. And same thing with other STI labs. We don't have patient self swabs like throat and anal swabs for chlamydia, gonorrhea in our healthcare system. So patients have to meet with a medical provider, which can be very uncomfortable, embarrassing for the patient. The provider might not even feel comfortable doing those types of swabs. And so patient self swabbing has been shown to be just as effective as clinician administered swabbing. So I think like working through some of those logistics can be a challenge.
Thank you, Dr. Rife-Pennington and Dr. North, and thanks to our listeners for joining in. To learn more about leveraging pharmacists' expertise to advance HIV treatment and prevention, click on the link in the show notes. And to get access to all of our podcasts, subscribe to the CCO Infectious Disease Podcast on your favorite player. Thank you and have a great day.